Hello everyone. The topic for today is very important. This is evaluation of dyspnea. This is the first cardinal symptom of respiratory diseases, and we will start with first a definition. The definition of dyspnea is basically a subjective experience of breathing discomfort that is either experienced by the patient as air hunger or it is described as chest tightness. Second is recognizing the signs of respiratory distress. This can be seen on only a general appearance of the patient. You should be able to make out that the patient is in respiratory distress and thus requires expedited assessment as well as management. He might be having a life-threatening condition. So the identification signs include tachypnea, the use of accessory respiratory muscles. Along with that, there are some intercostal or subcostal retractions. If there are any audible breath sounds like stridor, or there is an altered mentation. So you should remember that hypoxia generally leads to an agitated state, and if the patient is like verbally abusive, you should think that there is a potential airway obstruction. Whereas hypercarbia, like in COPD patients, will generally lead to a depression in the mentation, and thus the patient will likely be obtunded, will like to remain completely calm, and he will be not arousable. Whereas if the patient is pausing between words in a sentence, you should think of air hunger. So there is again a possibility for airway obstruction. These are features that can be seen in acute dyspnea, and thus they should be committed to memory. After that comes a very important and very beautiful diagram from Harrison. It itself summarizes all the mechanism of dyspnea. So I'll just give you a basic idea of this diagram. So dyspnea is basically produced either through an increased need pathway or an increased effort pathway. If there is an increased need, then generally there is a metabolic disturbance in such a fashion that ABG abnormalities are likely found. So there is hypoxia, hypercapnia, or acidemia in the patient. This information is sensed by the central and the peripheral chemoreceptors. So central chemoreceptors are present in medulla. The peripheral chemoreceptors are present in the carotid body, the aortic arch, and the aortic bodies that are present over there. The sensation that we get out of this, like from this increased need pathway. So this increased need means increased ventilation is necessary by the body. So the patient will try to inspire more, and this is experienced as air hunger. The need exceeds what can be provided by the respiratory system at maximal efficiency. So this is experienced as air hunger, and this afferent information will enter the brainstem as well as the sensory cortex. Subsequently, it will be passed to the brainstem and the motor areas of the brainstem and the motor cortex, and this will then lead to supply of respiratory muscles, and adequate changes will be produced in it. On the other hand, if there is an increased effort that is required, then generally there will be some evidence of resistance either in the airway or in the chest wall or in the lung or even in the vasculature, and these vasculature receptors are referred to as Metabo Receptors. In the upper airways, in the lungs, we have Irritant Receptors. I will write it down. This is Irritant Receptors, GA receptors, and various stretch receptors. These are present in upper airways and lung, whereas in the chest wall, you will have muscle spindles and Golgi tendon organs, which will act to identify this increased need and the increased effort, and that will be sensed by the patient as chest tightness. And the afferent information will again move to the brainstem and the sensory areas of the brain, subsequently pass to the motor areas, and subsequently the efferent output will be delivered through nerves to the respiratory muscles. After this comes the approach to the patient of a dyspnea. So you should remember that chronic dyspnea is defined as dyspnea that lasts for more than 1 month. There are very important etiologies of acute dyspnea that should be committed to memory, and these can be the causes of emergent respiratory distress in the patient. So this includes inhalational injury like in burn patients, or pulmonary embolism, pneumothorax, bronchospasm that includes asthma, COPD exacerbations, anaphylaxis, left ventricular MI, or pneumonia. This can also include various surgical diseases. So like for example, tension pneumothorax can produce acute dyspnea, or massive hemothorax can also do it. Tracheobronchial injury can do it, but we will restrict the discussion to medical diseases at the moment. Then chronic dyspnea can have again many causes, like pulmonary and cardiac are the ones that should be considered first. Apart from this, one more cause that is of very high yield, or it is very likely to be prevalent in the Indian population, is anemia. And this is a very preventable cause and very treatable cause of dyspnea, and it should be remembered. And then in the evaluation, the approach will be the same for all patients. For any case, you will first obtain a history and then subsequently move to a physical examination. The sequence of history and physical examination does not change, and the components remain the same. There are some key findings that can be obtained from a history, and they can be seen in the physical examination that will point to a specific diagnosis. Please look into the textbook to have a knowledge of what type of diseases can present as dyspnea and what could be their potential findings. Not everything can be summarized through notes. So I will just give you a basic idea that if the patient is having orthopnea and paroxysmal nocturnal dyspnea, then you should think of heart failure. So orthopnea means the patient is having difficulty breathing when he tries to lie down, whereas platypnea means the patient is having breathing difficulty when he stands up. Rather, when he is supine, then the patient is normal. Okay, so and orthodeoxia means the fall in oxygen saturation that occurs after the patient stands from a supine position, and if that occurs, you should think of hepatopulmonary syndrome or cirrhosis. Okay, so why this occurs is because of the opening of the arteriovenous channels in the pulmonary vasculature, and these get compressed by diaphragmatic elevation in the case of cirrhosis. And when the patient stands, the diaphragm moves down, the abdominal contents descend. If the patient has ascites, then the ascitic fluid moves down, and these channels will once again open up. And if these channels open, the blood will bypass the capillary circulation and enter into the right, from the right to the left side of the heart, and that will produce a decrease in oxygen saturation because it will now act as shunt. Why this particular shunt is created? The reason for that is in cirrhosis there is massive vasodilation because of increased amounts of nitric oxide that are produced. So because of that reason, we will have massive vasodilation, and it will open up these arteriovenous channels. So this is one diagnosis that you can suspect if the patient complains of such a type of difficulty. Then if the patient experiences chest pain, on auscultation you hear a left ventricular S3 heart sound. If there are basal creps that are auscultated in the lung fields, and if there is ASCVD risk factors present in the patient, this includes smoking, hypertension, diabetes mellitus, and hyperlipidemia, you should think of the possibility of MI in the patient. And now, because he is presenting with acute dyspnea, he might be landing into cardiogenic shock because of this MI episode. And if there is very specific history of some characteristic drug exposure or some occupational exposures or some autoimmune disease like RA or SLE, there might be a possibility of an interstitial lung disease causing the chronic dyspnea in the patient. Important examination findings can include the inward movement of abdomen in inspiration. In inspiration, generally abdomen will move out. If it moves in, you should think of diaphragmatic weakness. Whereas if there is outward motion of the abdomen during expiration, normally it has to move in. If it moves out, then you should think of pulmonary edema as a potential etiology. Unilateral pleural effusions can be seen in cancers. It can be seen in pulmonary embolism. It can also be seen in parapneumonic effusion. Then we have the grading of chronic dyspnea. Grading is done by MMRC scale, Modified Medical Research Council Dyspnea scale, on from 0 to 4. These are the various classes, and the basic theory of this is that if the grade is 0, then only strenuous exercise will produce it. If the grade is 1, then greater than normal activity will likely produce the symptoms. If the normal activity produces symptoms, then you should think of grade 2 dyspnea. If the patient has dyspnea at less than normal activity, okay, so he is not even able to walk for around 100 meters, then he is likely having grade 3 dyspnea. And subsequently, if the patient is completely breathless and is incapacitated or bedridden, then he is having grade 4 dyspnea. Then this is a simplified version of all the various differentials that are covered in Harrison. Not everything is there in this table. You should consult the book and you should gain perspective on how disease is present. This is just the most important crux of that table and the most important diseases that are covered in it. So I am covering only 3 important diseases. First, you should think of a pulmonary etiology that can underlie the process. Then you should subsequently think of some cardiac cause that could be underlying it, and there could also be some other causes that are not systemic in nature, that like includes like anemia and psychiatric disorder like panic attacks. So in these conditions you can see dyspnea occurring. The pulmonary disorders, they are divided into 4 major classes: the airways disease, parenchymal or interstitial diseases, the chest wall and pleura, and the pulmonary vascular diseases. These are the various disease examples that could produce such type of symptoms. Remember that chest tightness is experienced by the patient if there is a resistance, that is an increase in the effort, which can be seen in all of these cases. So patient needs to take a lot of effort to inhale or exhale, whatever. And whereas in pulmonary vascular diseases or cardiac causes or even variable causes, you will generally experience an increased need for ventilatory dive, and that will be experienced as air hunger. The key signs that will help us move towards this diagnosis is for asthma and COPD, you should think of the wheezing as a possible symptom, and the initial investigation will remain for pulmonary etiologies, spirometry or DLCO evaluation and lung volume measurements. And if it's a parenchymal or interstitial lung disease, then generally crepitations, clubbing or some exertional dyspnea could be likely findings. Then if the disease is chest wall or pleural in nature, then think of decreased diaphragmatic excursion, that is obtained on percussion. So here the maximum inspiratory pressure and the maximal expiratory pressures, these are reduced in spirometry. This is the diagnostic finding. And if that's a pulmonary vascular disease, then likely DLCO will be decreased, whereas all other features of pulmonary function testing will be completely normal. And if the disease is very long lasting, then right heart failure and right ventricular hypertrophy will be present. So jugular venous distension, pedal edema, and even cardiac cirrhosis would be present in the patient. Subsequently, left ventricle failure or pericardial disease can affect and cause dyspnea. Remember, in left ventricle failure, think of the most important cause, ischemic heart disease, that can lead to cardiomyopathy, ischemic cardiomyopathy. And in pericardial diseases, 2 important diseases include constrictive pericarditis and cardiac tamponade. So in all of these conditions, the immutable finding that is seen, that is, it is present in all these conditions. It includes pulsus paradoxus. This is one very important finding that might be present in all of these 3 conditions. And left ventricle failure signs, they can be seen in ischemic cardiomyopathy that affects the left ventricle characteristically. So you will see left ventricular S3 heart sound, and basal crepitations will be found. And in these conditions, because acute presentation is likely, like in cardiac tamponade or in left ventricle MI, you can go with Bnp testing, and Bnp is likely to be elevated in if the cause is cardiac in nature. And the general protocol for any type of cardiac disease investigation is to first obtain an ECG followed by a chest X-ray and advanced imaging that includes echocardiography and cardiac catheterization. These are the 4 most important investigations in the entire of cardiology. Then the important other diseases include anemia that can present as exertional dyspnea. The findings are generally variable. Obviously, you will be able to identify it on physical examination by pallor and increase in respiratory rate and heart rate, and blood pressure is a little less, and CBC value will help us identify it definitively. So hematocrit values and hemoglobin values will be on the lower side of the spectrum. In the psychiatric causes, say for example I am talking about panic attacks, the presentation is very acute. A clinician will first think of MI like cause and will order an ECG, but remember the ECG is normal in panic attack conditions, and that will help us include the diagnosis of panic attacks in this patient. Then the diagnostic approach in dyspnea is first to rule out a serious cause, that is a respiratory failure present in the patient. So if there is some respiratory failure, then the treatment has to be very fast, and you have to manage it accordingly. It can include even intubation and mechanical ventilation in the patient. So this is the first step. After that, you should think of the three most important causes. You should think of anemia, you should think of pulmonary cardiac etiologies. So you have to obtain the relevant history, you have to perform a relevant clinical examination, and with that you will be able to identify what type of which area of the respiratory system is being affected, and on that basis you will be able to order specific diagnostic investigation to lead to a specific diagnosis in the particular system. So whether it is asthma, whether it's COPD, it can be done on the basis of a meticulous physical examination and history, and also diagnostic evaluation. If all of this causes the diagnosis to remain obscure, in that condition you can go with the final testing that will help you differentiate between the cardiac and the pulmonary causes. It's referred to as the Cardiopulmonary Excise testing, CPET. The important point in this is what are considered the cardiac endpoints and what are considered the pulmonary endpoints. This is the only fact. That will remain important. This is the paragraph of Harrison that explains what we mean by the respiratory endpoints and what are the cardiac endpoints. That is when we should consider the disease is respiratory and when the disease is considered to be cardiac. So in the first condition, if the patient develops bronchospasm, if the patient has achieved at peak exercise the predicted maximal ventilation, or the patient experiences hypoxemia, think of a respiratory etiology behind the patient's dyspnea. On the other hand, if the heart rate increases to 85% of the predicted value, or suppose the blood pressure starts falling down or becoming high, okay, and there are ischemic changes that are present in the ECG, then likely the cardiovascular system is affected and is the cause of dyspnea in the patient. A graded approach to the diagnostic evaluation in dyspnea is very important. So initial testing is obviously guided by history and physical examination, but a general sequence is that the invasiveness of these testing, the cost factor of the testing should be kept in mind, and you should go for a graded investigation. If the patient's initial evaluation or initial testing does not reveal the diagnosis, only then you can move on to more additional testing that will help you obtain a specific diagnosis. So generally we will first go with history and physical examination and walking oximetry, which will confirm the diagnosis that dyspnea is present and it is likely due to a specific etiology. Always think of anemia, a pulmonary cause, a cardiac cause in the patient, and the effect on its system is respiratory failure present in the patient. So for that you can go with the basic metabolic panel and ABG values for the patient. To rule out anemia, you will go with a CBC examination. The basic investigation in all pulmonary and cardiac diseases is that you will go with an ECG. For pulmonary disorders, you will go with spirometry, and chest X-ray is obvious for examining both the pulmonary and the cardiac systems. This is the initial stage 1 evaluation of the patient. After that, if these initial investigations do not reveal a diagnosis, then think of enhancing the diagnostic testing, and now you can use CT scan. You can go for advanced pulmonary function testing, so you can obtain lung volumes. You can go with DLCO. You can also go with an echocardiogram if needed, if you are considering a cardiac etiology. And obviously if you are unable to make the diagnosis even on the basis of these tests, then it means that you have to go for CPET, that is cardiopulmonary exercise testing. This is the chapter. I hope you will read the book. Do read the book. You cannot go away with reading. So thank you.